Assalamu alaikum. The impact of different final irrigation activation techniques on postoperative pain in single-roted mandibular premolar teeth, a randomized clinical trial. This article was published by Tawfik and her colleague in 2025 in the European Endodontic Journal. The aim of the study was to assess the impact of different final irrigation activation techniques, including passive ultrasonic irrigation, the use of XP endofinisher file, the use of Fanta AF Max file, and comparing them to manual dynamic agitation on post-operative pain and analgesic consumption at 6 different time intervals. So the study included 64 patients that had single-roted lower premolars with acute irreversible pulpitis and apical periodontitis. And they were randomized into 4 equal groups with 16 patients in each group. The patient age range was between 18 and 40 years old, and patients with severe systemic disease or with mandibular molars with multiple canals or open apices, or teeth with sinus or swelling or retreatment cases were excluded from the study. So each group received root canal treatment with one of the previously mentioned methods for irrigant activation, and all of the cases were done by a single endodontist, and they were done in one visit. So after canal preparation was complete, the final active irrigation was dispensed at a flow rate of 5 milli per minute, and the time for active irrigation for every group was standardized for 1 minute. For the passive ultrasonic irrigation group, after placing the 5 milli of 2.5% sodium hypochlorite, they used an Ultra X device with the tip, which was adapted to reach short of the working length by 2 millimeter, and they used it in vertical movements to activate the irrigant. In the XP finisher group, after the passive introduction of the same final irrigant protocol, they used an 25 sized XP finisher file with 0 taper. This was done after the file was chilled, just to make sure that it stays straight in the canal, and it was done with using endo eye spray, and it was allowed to work at 100 or 1000 RPM and a torque of 1 Newton centimeter for 1 minute in a longitudinal movements to the entire working length. In the third group, AF Max files were used to activate the irrigant by working the file with 800 to 1000 rounds per minute and 1 Newton centimeter of torque. And this was done by allowing the file to move in an up and down movement in vertical directions for 1 minute until it reached the whole or the complete working length. In the final group, they used a 4006 cone-shaped GP to activate the irrigant manually by moving the cone in a coronal apical way for 1 minute, and the reported average rate of 100 strokes per minute was used. So after the treatment, post-operative pain was recorded through the VRS at 6, 12, 24, 48, 72 hours, and following 1 week after the procedure. The VRS consisted of 4 levels, of 0 being no pain, mild, and moderate and severe pain. So regarding the post-operative pain, pain was considerably higher associated with the manual dynamic agitation group compared to the other groups. But across all the groups, pain peaked at 6 hours post-treatment, followed by a secondary increase on days 4 to 6. And at day 7, pain and analgesic consumption was diminished significantly across all of the groups. As I said, the analgesic intake was the highest in the MDA group, followed by the Max file and XP finisher, with the PUI group had the lowest analgesic consumption, but there was no significant difference between the 2 file groups. And the same findings were also seen related to the swelling incidences. So in conclusion, minimal post-operative pain and analgesic intake was significantly less in the PUI group compared to MDA, which is the manual dynamic agitation, which makes us want to use either sonic or ultrasonic or even PUI if it's available in our clinics, instead of just manually activating the irrigants. Thank you.